I have been given a topic, hypertension, which is really bread and butter for all of us. Anybody sitting here from any specialty whatsoever experience in their home or in the clinic a patient coming to you with hypertension, be it a gynecologist, be it a chest physician, be it an orthopedician. And at some point of time, what happens is when we go into specialization and super specialization, our vision becomes more and more tubular. So what happens is when we find a high blood pressure at any point of time, we feel scared, just as I would be scared seeing an acute ectopic on cable. So my approach to the whole would be very sketchy. I promise not to go into details of studies. I promise not to go into details of academics, but would try to give you something which you would require in daily practice. And I would encourage more and more participation of you all with your questions, with your different difficult situations, where we can be a part to solve those. That would give us a better learning. At the outset, hypertension is a topic which we had been studying right from day one of medical profession. But even then, what has happened, you see, I think this is only the pointer.
Yes, sir.
This is slide changer.
Yes, sir.
Yeah, and this is the pointer. Yeah. So, the brief topics of the talk will be hypertension, Indian scenario, blood pressure measurement, an often neglected topic, a new topic of ambulatory blood pressure measurement, various guidelines and their catchphrases, the recent trials which have redefined the targets of hypertension, and the pharmacology of the whole thing. So, first, let me start with the Indian scenario. What you observe here. See, there is a prevalence of 27.6% in the rural population, which was much less. Though the urban population numbers have increased, but the rural population now has a considerable amount of hypertension. You see, the proportion of patients aware of hypertension status, the proportion of patients aware of hypertension status, 41.9%, not even 50% of the urban population is aware that hypertension is something and I may have hypertension. In the rural, it is abysmally low. 25% of the rural population have any idea about it. Proportion of hypertensives being treated is only 37.6% in the urban areas. And the proportion of hypertensives having BP under control in urban areas is 20.2%. In the rural areas, it is 10%. One must introspect why this is happening. Before I go to the next slide, I would love to tell you one thing. See, hypertension, if you see, it's a normal aging process. As we age, the blood vessels age and you have hypertension because of lack of resilience of the major arteries and the shrinkage of the small vessels. Now what happens? You must, when you face a patient in a clinic, the first thing is not to write a medicine. I repeat, it's not to write a medicine, but to tell the patient that भैया उम्र के साथ साथ बाल भी सफेद होते हैं, blood pressure भी आते हैं. Because the most important question of a patient is कल तक तो मेरा BP ठीक था, आज से क्यों blood pressure? आपका machine में कुछ खराबी है. He hops from clinic to clinic, and by the time he realizes that he really is a hypertension, he presents to you with a complication, either a CVA or an infarct or something of that sort. So the first meeting with a patient with hypertension is the most important thing, where we have to impress upon them, they accept it as a normal aging process. Now the aging may start at 20, किसी का बाल 20 में सफेद होता है, किसी का 80 में सफेद होता है. That depends on the genetics, environment, social environment, the interaction, his lifestyle, blah blah blah, so many things. But it is a normal aging process, has to be ingrained in their minds. Young age hypertension is a separate group, although we find this benign essential hypertension coming to young age now more, but young age hypertension has a different workup. But most of the patients that we face today are this, and first thing, until and unless we impress upon this, the next part of the step becomes useless, because he doesn't realize that hypertension itself is not a disease. Hypertension is only a risk factor. Diabetes mellitus is not a disease. It's a risk factor. It creates disease. The diseases are strokes, heart attacks and kidney failures, which once happens will not be reverted. Patient sleeps at night, gets up in the morning, has a CVA, you find a BP 220, 120, doesn't matter, it will come back to 120, 80. But the CVA will not recover. This is the thing that has to be impressed upon the patients so that you can have a compliance. Otherwise, lack of compliance is the most important thing for which the hypertension still today remains uncontrolled. Next part, blood pressure measurement. Again the most neglected thing. Why? A real blood pressure measurement takes you 10 minutes. But just touch your chest and tell me, how many of us give 10 minutes for a blood pressure management in a clinic? We don't have that time. And that leads to the fictitious high and fictitious low blood pressure measurement. I just give you one small example. Do you know how much speed the mercury manometer should come down if it is a mercury manometer while you take a blood pressure measurement? No, it should be 2 millimeter mercury per second. Why? Because there is an audio-visual dissociation. Light travels faster than sound. So, by the time the mercury manometer comes, if the patient has a lower heart rate, you are going to miss the first tap. Because by the time you have scrolled down to 120, your ear did not hear the things in 140, 130, 120. So you are recording a blood pressure to be erroneously low. It's very important. Today, there are no mercury manometers internationally. Only two things are permissible. Either you have an electronic blood pressure equipment, or at the most you have an aneroid blood pressure equipment. While checking an aneroid, so the measurement of blood pressure is a clinical procedure of greatest importance that is performed in the sloppiest manner. How many in your clinic have 3 blood pressure cuffs? Can you raise your hands? For an obese, a blood pressure cuff should cover 80% of the circumference and 2/3 of the distance between the olecranon and the acromial process. If it is shorter, if this does not cover the whole, you have an erroneously high blood pressure measurement. And if it is the reverse, you have an erroneously low blood pressure measurement. So, the problem of hypertension is there. It's not a problem. It's a normal aging process. It's we who complicate the process much more. We had been shouting that India doesn't do anything, but yes, Association of Physicians of India have done an incredibly good job by publishing the Indian hypertension guidelines. And I tell you honestly, comparing the JNC 8, comparing ESC guidelines, I find the Indian guidelines much more logical and rational. Therefore, I would quote this. An average 3 readings has to be taken at 2 to 3 minutes intervals. I swear we cannot do it. None of us can do it. In that situation, either we will not be able to finish our patients in the government OPDs, and in the private OPDs it is not worth the money. Therefore what we do? At least ask the patient from refraining from smoking and drinking 30 minutes before, and at least ask him to sit for 5 minutes before you check the blood pressure. These two at least you do. And try to measure the blood pressure nicely such that there is no gap between your vision and audition. It should be done preferably in a sitting or supine position, but while in sitting position, be very sure that your clinic staff or secretary holds the hand such that the mercury manometer is at the level of the heart. With aneroid you are at an advantage, but with mercury manometers it must be at the level of heart. If it is not that, again you are inviting trouble. With a lower position you have a higher blood pressure, with a higher position you have a lower blood pressure. The patient's arm should be fully bared and supported at the level of heart. Here a problem comes. In this winter, with all the clothing on, when you push the thing up, there is a resistance here. And once you have a resistance here, the artery is partially obliterated. So either you open up the whole attire and have the whole limb free, or you ask him to remove the pullover, have the full sleeves on while taking the blood pressure. There will be no squeezing of the brachial artery. That's very important. Advanced in all forms. Today in cardiology, we can straight away say one thing, that any chronic heart disease, any acute heart disease, any pediatric heart disease, 75 to 95% we can give you a normal life. But it's not because of the technology, it's not because of the investigations, it's only because of development in pharmacotherapy. And what we are missing today is clinics. So I emphasize that the basic clinics we learn in medical school should be followed every day. A patient with a hypertension, when he sits in your clinic, just do 3 things. Check the pulse in the hand. Simultaneously check the pulse in the dorsalis pes. If they are dissociated, you have diagnosed a coarctation. Check the blood pressure in both arms. If they are low, variation more than 20, you have diagnosed some sort of subclavian obstruction, whether you are dealing with a TACA issue or not, or aortoarteritis as it is. When you just put your stethoscope on the supraclavicular, axillary and back, you diagnose 3 things. A bruising, a lack of carotid pulsation, and a pulsation in the back, interscapular lesion, gives you diagnosis of aortoarteritis, TACA issue, coarctation. So 3 important diagnosis in young age hypertension is just from basic clinics. You are examining a patient, suddenly you find the patient is having tachycardia and sweating. Keep in mind whether you are dealing with something adrenergic, something histaminergic. That is either an adrenal tumor or an epiderma which causes secondary hypertension. Doesn't require much things, only basic clinics. I'm sorry. So this is what I had said. I don't think I would go into it further. ABPM. Before going into ABPM, I want to tell you one thing. Every day in the clinic you will hear one thing. डॉक्टर आपके यहाँ जब आते हैं तो बीपी 150-100 दिखाते हैं, घर में जाते हैं तो 110 लो हो गया है, बिल्कुल लो हो गया है. ब्लड प्रेशर कभी लो नहीं होता. दिस इज द थिंग दैट हैज टू बी इम्प्रेस्ड अबाउट एवरीथिंग. चलता फिरता इंडिविजुअल्स का ब्लड प्रेशर कभी लो नहीं हो सकता, कभी लो नहीं हो सकता. जस्ट टेल यू वन थिंग, योर होल बॉडी इज अ क्लोज्ड ट्यूब सिस्टम. ओके, so in a closed tube system, it is the heart which is maintaining the pressure in the tubes. How can the pressure come down when the pump maintaining the pressure is defective, when there is leakage in the system, and you imagine putting bleeding, diarrhea, infarcts, heart failure. Other than this, the blood pressure cannot go down. So what is happening is blood pressure variability that is happening. And that is true for everybody because of your circadian rhythm. When we give medicines, we do not take care of this. Medicines who have a good peak and trough ratio, that means they are spanned over 24 hours, gives you the best coverage. Can you tell me which is the time when you have the maximum amount of vascular catastrophes? Early morning. Early morning. Why? Yes, sir. Yes, sir. Yes, sir. Because the total cortisol release kinetics is, it peaks at 4 a.m. in the morning, it nadis at 9 p.m. at night, it is away from the blood, it's away from the blood by 12, and it again starts rising till 4. So that period you are virtually bereft of the most important police force in your body, the cortisol hormone. So that is the time you have maximum vascular catastrophes. That is why in blood pressure, the most important thing is whether the patient is a dipper or a non-dipper or an elevator. That means normally the blood pressure dips at that point of time because of wash away of cortisol. But there are persons who do not have a blood pressure dip. There are persons who have a blood pressure rise. These are the persons who have the maximum vascular catastrophes. How do you identify them? How do you identify office hypertension? How do you identify white coat hypertension? ABPM is really the answer. Because today, just as home blood glucose monitoring, home blood pressure monitoring has the most important place in blood pressure management. ABPM is ideally a 24 hours clockwork of this, and it gives you very clear ideas as to where your blood pressure was at the high level. Was it during office? Was it at bedtime? And so you can manage your drugs accordingly. These are the things: borderline hypertension, white coat hypertension, isolated systolic hypertension, nocturnal blood pressure, resistant hypertension, hypertension of pregnancy, and patients having hypotensive symptoms. Now, hypotensive symptoms can be 3-4 types. One is the routine vasovagal or neurocardiogenic syndrome. Second is orthostatic hypotension that you have in aging patients, Parkinson patients, normal patients who are on vasodilators, alpha blockers. So you have those. So the hypotensive response, how do you know about it? ABPM gives you a very clear outlook as to this. So, in ABPM, according to the European Society of Hypertension recommendations, the awake optimal blood pressure is 130/80 and asleep is 115/65. Blood pressure is a range and not a number. The normal is 135/85 and 120/70. Abnormal is 140/90, 125/65, while asleep is an abnormal blood pressure response. Now, with all these, there were certain limitations also. But these limitations are gradually being overcome by the sleep ABPM equipment that we are now having. All the comfort and zones are being taken care of. There was initially tracking errors that are being taken care of. The very important thing was noise, which is now being taken care of. Now, guidelines. I will not go into the details of it. Let me tell you one thing. The present guideline is less than 140/90. There has been a controversy of late with the publication of 3 major trials: Accord, HOPE-3 and SPRING. They are in 2 different directions. Let me tell you a story. At the time, when Abraham Lincoln was the president of America, there was a concept that you do not reduce blood pressure because it is a normal thing. That is why it is called benign essential hypertension. That is, you have to have it with age, so you don't reduce it. The maximum recorded blood pressure at that point of time was 300 by 180. They used to do a bit of bloodletting at that point of time, nothing else. Then came three very important studies. Yes, Franklin Roosevelt died of that. Then came three very important studies. Number one, Veterans Affairs study, Stop Hypertension trials, and Cystute trials. They showed that if you reduce blood pressure, there is a mortality benefit. Then the thing dawned in the mind of people that you need to have reduction in blood pressure. But that was person to person basis. What you felt as a physician, you did it. But then the drugs started coming out one after another. So people started thinking that there should be a guideline as to which drug should be given, where it should be started. So you had the Joint National Committee Guidelines 1. What was observed at that point of time was, what should be the ideal blood pressure? Only one study gave an answer to what should be the ideal blood pressure of the diastolic group. That was HOT study. They had three different arms which showed that below 85 diastolic blood pressure produced the best translational benefit. So the question of diastolic blood pressure was solved way back in 90s. After that, what happened? After that, series of studies started getting published with the systolic blood pressure. Some said it should be 120/80, some said in diabetics it should be less than 120/80, some said no, it should be less than 130/85, and everybody coming up with data. But I tell you, if you look at the studies in details, nobody actually achieved blood pressure in the studies less than 140. But everybody started claiming this. Then came the mysterious concept of J-curve, that as you lower the blood pressure, the mortality goes on rising. This J-curve we studied when we were doing our post-graduation in 1992. Then from end 90s to 2000 mid, the J-curve disappeared. Everybody said that there cannot be a J-curve. Again there has been a resurrection of J-curve, that yes, there is increased mortality, and that is what Accord studies say. That in diabetics, if you lower the blood pressure less than 130/80, or you lower the blood glucose very tightly, mortality is increasing. Accord has its criticisms that it was not a study powered for mortality, there were many things in there, blah blah blah, this all came up. But it gave the first day. Hope 3 came after that. Hope 3 supported Accord. Then came Sprint, which reversed the whole thing. Sprint said no, you lower the blood pressure less than 130/80, there is cardiovascular mortality benefits. So this controversy went on going on. Therefore, I will not dwell into this, because this is a thing which is not for us. I will at the end tell you what should be the present approach to management in hypertension in the last slide. Before that, I would say this guidelines. I was talking to you that guidelines had come out. You remember there was a time in 90s when all of us used to start with diuretics. And then we used to add something, then we used to add something. That was called the step care approach. 7 years back, the step care approach disappeared. They said a tailor-made approach. So there will be some starting drugs, but there will be the physician choice in between. 2 years back, suddenly, British hypertension guidelines removed beta blocker from the armamentarium of hypertension management. Why? Because there was a series of studies which showed that atenolol that was used in the study never resulted in mortality benefits. So everybody stood back. So no beta blockers in hypertension management. JNC8 did not remove it. Now, do you know anybody why beta blockers were removed from hypertension management? What was the logic? Anybody?
In our surgery, usually we are afraid of cardiac block at the time of anesthesia. Only that is a contraindication of the beta blockers.
Sir, right?
I don't know.
Yeah, in younger patients, when older generation beta blockers were being used like atenolol, the incidence of diabetes was going on, especially when it was used along with high-side diabetic like hypoglycemia.
Exactly. And the most important thing was, older generation beta blockers never reduced the central aortic pressure, which is responsible for the vascular catastrophes. That is why ACE inhibitors, ARBs, calcium channel blockers fared better than atenolol. But recent generation beta blockers who have vasodilating properties, like nebivolol, like metoprolol, like bisoprolol, they reduce the central aortic blood pressure. So removing beta blocker from hypertension management was not a choice. That is why I say that Indian guidelines were very much justified, because you see, in Indian guidelines they have retained beta blockers as newer beta blockers. So this was a eye-opening guideline to the world, that they retained newer beta blockers in younger age group. Other than that, hypertension, associated disorders of cardiac problems, you were using beta blockers, you will be using beta blockers till now. But per se hypertension management, beta blockers were put back for last 4 years only after Indian guidelines and JNC 8 statement came out that we have restarted using beta blockers in management, a newer generation. Fixed dose combinations. Just see that these fixed dose combinations are not nonsense combinations. That is a thing you have to see. For example, a very commonly used combination, Cadila may hit me hard, but I tell them, telmisartan beta blocker. It's a useless combination for hypertension, because both act through the sympathetic nervous system pathway, so there is no synergism. So why is it used? It's a wonderful combination in heart failure management. It's a wonderful combination in heart failure management. If you combine ACE inhibitors or ARBs with calcium channel blocker, superb combination, because it reduces the edema of calcium channel blockers. If you combine beta blockers with a diuretic, there is a chance of increase in blood sugar levels, no doubt, but the action of beta blocker is potentiated with diuretics. Diuretics with calcium channel blocker is a wonderful combination for elderly hypertensives. So just see to it that the combinations are not nonsense combinations. Polypills do reduce one thing. एक चीज है, हम जब लिखते हैं ना, अगर वो किराना भंडार का एक लिस्ट बन जाता है, तो पेशेंट क्या करता है, 4 डॉक्टर्स के पास जाते हैं और जिसमें से कॉमन दवा है वो खाते हैं, वो हमेशा बी कॉम्प्लेक्स होता है, ठीक है, बाकी चीजें वो आसानी से हटा देते हैं. So that is why try to make your prescriptions as brief as possible. If you are to use, see, most of us face resistant hypertensions in the OPD, all the senior practitioners. Their combinations do help us in giving you that mental tonic that हमें तो 3 ही दवा खाना है. So that is where polypill is good for us Indians, although it is not in the West, because they are a chartered guy, they would love to have it 1, 2, 3, 4, 5, 6. Just as they maintain diary, we don't. That is the outlook. This is all I have said. So beta blocker is gone. I would not go into the study I have promised. Recent trials I have already told you the story about it. Because going through this is pretty boring. Special cases. Hypertension in diabetes. Less than,
you mentioned about that early morning heart attack.
Yes, sir.
People nowadays the different, all are overweight, all are old age. People taking alpha blocker
Yes,
for
sir.
their prostate. They take at night
Yes,
because
sir.
hypertension position nahi ho. So what is the actually implication of this thing? Morning they get the heart attack because we get the hypotension also due to this alpha blocker. What is the indication? Should it be given or not?
Yes, sir.
What is the advantage? What is the disadvantage?
We give all alpha blockers not only for benign hypertrophy of prostate but also alpha blockers in hypertension. For example, doxazocin and this prazosin. We give it at bedtime only for one reason, that by the time you are in the morning, the postural hypotension effect decreases a bit. Otherwise, if you give it in the daytime, that gentleman for first 1.5 months, till when this postural hypotension, there is alpha blocker will not further lower it. It takes for alpha blocker to get habituated with it for 1.5 months. So this postural hypotension with all the alpha blockers remains in the first 1.5 months, not after that. Okay, so that's the reason we give it at night, so that it is not discomforting in the morning. If you give it in the morning, he may have a fall during seeing a patient or doing an OT. So, accord showed 130/80, less than that is enough for a blood pressure in a diabetic situation. Nothing more to go beyond this. So, goal blood pressure I have already told. Non-diabetic adults with CKD, it's less than 140/90. For normoalbuminuria, any blood pressure patient who comes to you should have a urinary albumin estimation done, because that shows two things: the effect of the kidney and the progress of atherosclerosis. It's a surrogate marker for the progress of atherosclerosis as well as a marker for the progress of kidney disease. So, if it is a normoalbuminuric, it should be less than 140/90. If you have a microalbuminuria, once you start having microalbuminuria, you are in stage B. Up to this, it is reversible. After this, it is not reversible. So here the blood pressure should come down less than 130/80. If it's a non-dialysis dependent CKD, less than 140/90. If normoalbuminuric, again, if there is macroalbuminuria or microalbuminuria, it should be less than 130/80. Kidney transplant patients should be less than 130/80, and elderly people with CKD, it should be less than 140/90. So aim less than 130/80 if you have albuminuria present. Morning versus evening, dosing of the drugs. Try, if you are using 2 antihypertensive, try to use one antihypertensive in the morning, one in the evening. That gives a better coverage than putting 24-hour acting antihypertensives together at one point of time. That has been in many of the studies, but this consensus is yet to be achieved, because now we are having longer and longer acting antihypertensives, so the peak trough ratio is being well controlled. If you give it in the evening, the morning surge is well controlled. So what I do in my personal practice is, if I have to use a telmisartan and an amlodipine, I would prefer giving an amlodipine in the morning and a telmisartan at night. You will ask me why? For only one reason: amlodipine given at night induces diuresis. So the patient goes to the toilet quite a number of times. If you change it in the morning, I had a patient, mother of a doctor. For 5 years, she had not slept. She used to sit in the bathroom. She used to go 4 times, 5 times, 6 times at night.
What's the mechanism? Amlodipine induces dialysis.
Amlodipine causes saltwater retention. That is why you have edema. The same causes, amlodipine causes more of diuresis at night. So just switch the calcium channel blocker in the morning and your whole nocturnal enuresis pattern will go away. Secondly, those who are compulsive fluid intake, we have in hypertension management, that is also a very important thing. try to understand who are compulsive water drinking persons. As a society, as a culture, we are forced from childhood to be compulsive water drinkers. That causes two major things. The blood volume increases, causing a resistant hypertension. You have a dilutional hyponatremia, so when you use diuretics, they go more and more into hyponatremia, and you have everyday admissions. Those who work in the critical care, person receiving thiazides come to you with hyponatremia like a CVA. That is the commonest finding in critical care today. Cover this up, ask them to have 3 liters of liquids, not water. Because 1 cup of tea is 200 ml, 5 cups of tea is 1 liter, 1 katora of dal is 250 ml, 2 katora of dal is 500. So you have 1.5 liter intake from here only. So if you add 3 liters to it, it goes to 4.5 liters. So in summers it should be around 3 to 3.5 total fluid intake, and in winters it should be between 2.5 to 3 in tropical countries. That helps in reducing hyponatremia. At the same time, please don't stop salt. Once again I repeat, this is a thing I have repeated it everywhere. Try to understand that the concept of salt restriction is geography and ethnicity specific. Try to have a detailed history of the total salt intake. According to guidelines, you should take 5 grams of salt or 6 grams of ionic sodium per day. For hypertensive patients, we prefer to have it between 3 to 5. Studies have proved that if you reduce salt less than 3 grams, you increase mortality in management of heart failure. Already the recent studies have come out. So 3 to 5 grams. Imagine in a family, there are 4 adults. So 5 fours are 20 grams. Can you imagine the amount of salt? Oh, sorry. 20 grams is the amount of salt that you have to take per day. So when we say no salt, what do? They remove salt from the food. They do not take additional salt even if they perspire like a hog, and you are giving diuretics as first line management. Now if you talk about East Bengal, they have seawater fish, they have the fish stuffed with salt, everything they eat is stuffed. If you go to the west, they have achars, papads, pickles which are impregnated with salt. In Western world, they have jams, jellies, cheese, everything containing sodium bicarbonate as preservative. They have tinned fish, tuna, everything has sodium bicarbonate as preservative. Salmon, sardines come from the sea. So the total salt in an urban society, which they call themselves, is very high. But think of us Indians. There are many Indian societies where our food, fresh vegetables, fresh fruits, they do not contain salt. So this salt chapter has to be dealt with per patient. So in the history, try to find out what is the individual consumption of salt. Your chlorthalidone adherence will be much better. And number 2, chlorthalidone or any diuretics, they work by sodium depletion from the proximal convoluted tubule or ascending limb of loop of Henry, depending on thiazides or furosemide. In the first 2 weeks, after first 2 weeks, their antihypertensive action is because of vasodilatation properties. So if you use low dose thiazides in the first 2 weeks and then step up to 12.5, you will never have adherence problem with the patient. They will never complain of fatigue, giddiness and weakness. The most important problem of adherence can be very well met this way. Please, again it has come back this way, sorry. I think I have come to the end of the thing. After this, if I go on speaking of hypertension, it will go on and on and on. I have Dr. Prasad just after me, so I will just wrap up very fast. So the hypertension categories. Well, stroke, heart failure, elderly, coronary artery disease and renal. 5 of them have 5 different management of blood pressure as of today. So there is no code which is just fitting to everybody. You have to fit everything in its own perspective. For example, stroke. If you have a hypertensive stroke, the outlook is different. When a hypertensive stroke with intracerebral hemorrhage, the outlook of management is different. If you have an ischemic stroke or an embolic stroke, the management guidelines are different. If the patient has a heart failure, the approach to management is different. Renal I have already discussed because this you are facing every day in life. Coronary artery disease, those who face, let them tackle it. And elderly people, I have to talk of isolated systolic hypertension. And if I start talking about it, it will take another 2 hours. So I would prefer leaving this to you. When you ask questions after the session, I am ready to answer all of them. Thank you very much for the patient hearing. Lipid profiles. So lipids कहाँ से शुरू करें? Hypertension and lipid profiles. Yeah, plain lipid profiles. Regarding lipid profiles, let me tell you one thing. There are 3 things. One is cholesterol, one is triglyceride, the other is HDL. All the controversies go in between this. LDL cholesterol has to be lowered. Full stop. Lowering of triglycerides have provided benefit in some, did not provide benefit in others. Triglycerides produce small dense LDL which are definitely atherogenic, but there are 2 problems in it. One, there are seldom large trials where triglyceride reduction has translated into statistical benefit. So lowering of triglycerides is more for the pancreas than for the heart. So if you have a raised triglyceride level, go with a statin only until and unless the TG is more than 400. Okay? And for HDL, n number of drugs elevate HDL. But remember one thing, no elevated HDL by drug, even in the recent trial in high, have translated into any benefit so far. Because HDL has number of different molecules which perform different activities. So when you have a low HDL, try to lower the cholesterol using a drug which does not lower HDL further. Rosuvastatin is a choice in those situations. Atherosclerosis lowers HDL. Thank you so much.
Thanks, Dr. Arunangshu, for your excellent talk.